Now look at the notes for Extract 1.
You hear an otolaryngologist talking to a patient named Terry Butler. For questions 1 to 12, complete the notes with a word or short phrase. You now have 30 seconds to look at your notes.
Good afternoon. Mr. Butler, is it?
Yes, Terry Butler.
So your GP has referred you because of a problem you've been having with your nose. Can you tell me more about it, please?
Well, it's usually when I first wake up, I get a terrible crusty mucus, but it tends to stay around for the whole day. It's been irritating me for a couple of months, actually. I initially thought it had just resolved by itself, but it hasn't. The thing is, and I know it's a bit disgusting, but sometimes when I try to get it out, I've had a little bit of bleeding. It's not a lot by any means, but enough to notice.
Right, okay.
I've also noticed, for example, when my wife puts on perfume, it's my sense of smell. I can't seem to detect it as strongly these days, so I'm a little concerned over that. I mean, I can still breathe, of course, but it's worrying. I actually thought I was allergic to something because we'd recently adopted 2 cats, or maybe it was, I don't know, dust mites or the season, because I suddenly started sneezing. Not all day, but still quite often, regular sneezing. But that's not the case, apparently. I know this condition isn't dire, but it does affect my life. The blocked up feeling can really hurt sometimes.
I'm sorry to hear it's caused you so much worry.
Well, I'm also concerned about my job. I'm a hire car driver, and it's mostly for high-end clients, so it involves a certain degree of professionalism. The last thing I need is to be seen constantly playing with or twitching my nose, or worse still, sneeze and cause an accident.
So you don't believe it's allergies related?
Well, not as far as I know. I've been to my GP, as you know, and tried to rule things out. First I had a skin prick test, and that didn't show anything, so I went away thinking it'd clear up. But then after a few weeks it was still annoying me, so I had a blood test, but that apparently came back clear. But I keep thinking maybe it's something less common, and that's why nothing's shown up. My GP asked if I'd been ill because he thought perhaps it was caused by a viral infection, but I hadn't been. He also asked if I was taking any medications that he wasn't aware of, like beta blockers or antidepressants, which I wasn't. In fact, the only thing I'd started using around that time was a nasal decongestant spray that I'd bought from the chemist, which he then advised me to stop. He thought maybe I'd been using it too much, so I did, of course, but doing so didn't seem to make a difference.
I see.
And he suggested I try a few to see if they make a difference, so I got a humidifier. That apparently helps with the dry air and therefore to loosen the mucus, which was okay, but didn't make too great of an impact. He told me how to make up a salt water solution. It's much cheaper than buying it from the chemist. I still use it now, and that helps a little too, but just not for long periods of time, so I have to keep it up a few times throughout the day. Before going to bed, he said I should take an antihistamine, but again, it just doesn't seem to last too long, and before I know it, I'm feeling the same as before taking it.
And how's your health generally?
I'm typically as fit as a fiddle. I quit smoking 14 years ago because of a number of recurring lung infections at the time. They were enough to make me wake up to myself and finally go cold turkey. As for alcohol, well, I've been having my regular nightcap of whiskey for 20 years. Always the same brand, and I always stop at 2. As I said, I'm reasonably fit for my age. I go to the gym regularly. I've been involved in a cycling club for a number of years. We're a medium distance group and average around 60 kilometres an outing, so not too shabby.
That's great.
So, do you think there could be something wrong with my nose?
Well, that's what we intend to find out. The way we do that is by performing a nasal endoscopy. It's a very thin and flexible
Extract 2, questions 13 to 24. You hear an eye specialist talking to a patient called Jasmine Burton, who has recently undergone eye surgery. For questions 13 to 24, complete the notes with a word or short phrase. You now have 30 seconds to look at the notes. I've got your notes here, Mrs. Burton, but as we're meeting for the first time, could you begin by telling me a little about your eyesight and the treatment you've had over the years? Did you wear glasses as a child, for example?
Yes, since I was about 7. My parents were concerned by the way I held a book when I was reading, so they took me to an optometrist. He told them I had some kind of astigmatism.
Am I right in assuming that's myopic rather than hyperopic?
Well, yes, I'm nearsighted, if that's what you mean.
That's right. Some people actually have mixed astigmatism. They're far-sighted in one eye and near in the other.
Oh, well, that's not me.
Right.
And as well as my astigmatism, as you probably noticed, my eyes flicker. I'm not aware of it myself, but other people comment on it sometimes. I think you call it nystagmus. It meant that when I had my eye surgery, they preferred to use a general rather than a local anaesthetic.
OK, so did anyone ever tell you what they thought might have caused the condition?
Well, I was once told that my generally poor eyesight is most probably down to the fact that I don't have enough pigment in my eye.
Right.
On the whole, my eyes have never really caused me any significant difficulties, however. I've always had to wear glasses, so that's part of life now. I suppose the only thing is that driving's always been out of the question. I'd never have passed the sight part of the test. That's probably a good thing because it takes me some time to focus, which could make me pretty dangerous if I was ever behind the wheel of a car.
Yes, indeed.
Also, I'm useless at sports like tennis. I think that's because I'm poor at judging the distance between myself and the ball. That was a pain as a teenager, but I've never particularly wanted to play since then. And I've hardly had any issues at work because of my sight. I'm a receptionist in a hotel, and I've never had any difficulty reading computer screens or anything, fortunately.
You've had your eyes regularly checked throughout your life, presumably.
Yeah, that's right, every couple of years. My prescription has changed a little over time, but not that much. Though I certainly couldn't manage without reading glasses these days. About 3 years ago, I was told a cataract was developing in my right eye.
Right.
It was a few years before they decided to remove it. That was this February. And it all went very smoothly.
Good. And you were pleased with the result?
Yeah, I was. Yeah, thrilled. If only all our failing parts could be replaced so easily. However, when I had the routine checkup a couple of weeks after the operation, I was told there was some clouding, opacity.
Opacity, yeah.
I think was the word they used, in the capsule containing the new lens. It's a bit disappointing. They could clear it with a laser if it gets to be a real problem, but my flicker makes that rather a risky option. I knew that there's a greater chance of developing a detached retina after a cataract op.
Yes.
But I'm glad to say they found there wasn't any evidence of that in my case.
Oh, good.
All they did was make an appointment for me to be checked out again in 6 months' time. But they said I should get in touch if I felt concerned about my eyes.
And is that what brings you here today?
Yeah, because I am bothered about a couple of things. So firstly, I've noticed more floaters than usual.
Right.
I don't know if that's something to worry about or not. More annoying is the fact that I'm much more troubled by glare than I used to be, so I wanted to ask your opinion on that.
OK, well, let's start by...
In this part of the test, you will hear 6 different extracts. In each extract, you will hear people talking in a different healthcare setting. For questions 25 to 30, choose the answer A, B, or C, which fits best according to what you hear. You will have time to read each question before you listen. Complete your answers as you listen. Now look at question 25.
You hear a doctor and a nurse reviewing a coma patient.
Okay, this patient has been out for some time now. We had quite difficult intracranial pressure control yesterday. We decided not to rock the boat, and you can see as a result he had a low intracranial pressure all day. His circulation has stayed quite stable, blood pressure's good, heart rate's low. What are his pupils doing?
They're quite small.
So they're smallish, but not tiny. Is he showing any reflexive responses?
No.
Has he got a doll's eye? Let's have a look. Okay, is he coughing when you suction?
No, he isn't.
Not coughing? Okay, this indicates that at best, his recovery will probably be incomplete. The worst option is that he will remain in a coma with little responsiveness.
You hear a consultant emergency doctor talking to a patient following an accident.
Hello, Ellen.
Hi, Doc.
Can I just take a minute to talk to you about the injuries we found?
Sure.
So firstly, your neck looks fine. So in a minute, I'm going to get this brace off and you'll be able to move your neck. But you've got a fracture of your shoulder blade, a fracture of your thigh bone, a fracture through the tibia and fibula, the lower leg bones, and there are also fractures in your ankle, the talus, your heel bone, and the ankle joint above it, the calcaneus. We were quite worried about the blood flow past the fracture in your thigh, so we did an angiogram and a CT scan, and they actually show good blood flow. So with these injuries, you're going to need surgery, and it could be a bit complicated.
You hear a clinical researcher introducing a professional development workshop. Welcome to this workshop, Understanding Clinical Research Statistics. My name is Ivan Saxon, and I'm going to lead the workshop today. I'm the head of the Acute Care Surgery Unit. It's an academic unit in the Department of Surgery. This course is not the mathematics of statistics, though. I believe that a first contact with medical statistics should lead you to an intuitive understanding of the ideas behind the numbers. It should leave you with a deep sense of understanding what is meant by the numbers and techniques mentioned in the methods and results sections of published research papers. In order to critically evaluate research, you should be able to read more than just the introduction and conclusion sections of a paper. Quickly scanning for some significant p-value isn't enough. The patient population trusts you to be properly informed when you manage their health, so that's why we're here. You hear an emergency ward doctor directing her team while treating an accident victim. Okay, let's get on with the primary survey. It's a serious injury to his left leg. It's extremely pale, so blood flow could be an issue. But I'm worried about other serious injuries that aren't so obvious. A fracture of the pelvis, abdominal or spinal injuries. I think we better get the consultant emergency surgeon down here too. Okay, so you need to get the lines in, blood off, and we need to remove the rest of his clothing. We're going to want to get some x-rays done before anything else. Chest, pelvis, femur, please. And can somebody get a Doppler, please, so we can check his blood flow in the leg? You hear a doctor speaking to a woman who has presented with heart palpitations. And do you feel short of breath with the palpitations?
Yeah, and I'm losing my voice too.
So you'd just got to work and this happened?
Yeah.
When's the last time it happened?
A few months ago. I came here as well.
Okay, so I'm just going to try and massage the side of your neck here, just to see if that slows down your heart rate. Did they teach you how to try and hold your breath last time?
Yes, they did.
Did you try that this morning?
Yeah, I did.
Oh, great. Very good. Okay, well, that massage doesn't seem to be working. Let's try something else. What I want you to do now is to blow as hard as you can into this syringe. Ready? Blow, 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 blow. And stop. That doesn't seem to be doing much either. All right, we need to drop that rate, so we better try some meds. You'll need a drip. You hear an emergency paramedic talking to an accident and emergency doctor about a patient who has fallen from his motorcycle. This gentleman's name is Brian. He came off his motorbike at a corner and his leg hit a telephone box.
Oh, I see. Looks like he fell pretty hard.
Yeah, when we arrived he was sitting up and talking, GCS 15 and no signs of head injury, just some pain in his right shoulder, but the main injury is a deformed and angulated right femur, which we've manipulated on the scene.
How's his circulation around the leg?
He had a cold avascular right foot at the time, and the blood supply seems to have come back post-manipulation. Numbers-wise, he's normal. He's had 150 milligrams of ketamine and a total of 8 milligrams of morphine as well.
That is the end of Part B. Now look at Part C. Part C. In this part of the test, you'll hear two different extracts. In each extract, you'll hear health professionals talking about specific aspects of their work. For questions 31 to 42, choose the answer A, B, or C, which fits best according to what you hear. Complete the answers as you listen to the audio. Now look at Extract 1. Extract 1, questions 31 to 36. You hear the discussion between a senior doctor and junior doctors about volvulvas. You have 90 seconds to read questions 31 to 36. Hello everybody. I am going to explain to you about volvulus. The word volvulus is derived from the Latin term. It is a subtype of abnormal gastrointestinal rotation. In volvulus, a loop of intestines is twisted at a point along the mesentery, attached to the gastrointestinal tract. Volvulus may result in bowel obstruction that is considered as a medical emergency. Because there is not a blockage, but there is also a compromised vascular supply to the gut. There are 4 primary mesenteries found within the abdomen, and as a result of it, there are 4 corresponding primary types of volvulus: gastric, midgut, cecal, and sigmoid volvulvi. Gastric volvulus occurs when our stomach twists at least 180 degrees around its mesentery, resulting in obstruction of the bowel. Patients with gastric volvulus may be present with Borchards triad, which are spontaneous and severe epigastric pain, uncontrolled, producing vomiting, noises without a vomit, due to the impossibility of passing a nasogastric tube through to the gut. There are 2 subcategories of gastric volvulus. Organoaxial volvulus tends to occur after traumatic events or hernia of the periesophageal area. The stomach rotates along its long axis, that is along the path between the pylorus and the cardia. This condition is usually symptomatic when the rotation is more than 180 degrees and causes ischemia in addition to obstruction. Mesenteroaxial volvulus tends to occur very frequently in children. The rotation of the stomach along its short axis, that is along the path perpendicular to organoaxial, or the pathway between the lesser and greater curvatures of the stomach. The treatment of gastric volvulus, which may involve an emergency laparotomy, insertion of gastrostomy, percutaneous tube, and hernia and diaphragmatic damage repair. The surgery is primarily aimed to reduce the degree of twisting and prevent any chances of recurrence while taking care of factors that create a predisposition. Midgut volvulus begins in newborn with sudden bilious vomiting. In addition, the abdomen becomes tender as it fills with fluid that accumulates within the bowel lumen, and followed by inflammation of the peritoneum and shock. Patients with midgut volvulus typically have a corkscrew sign visible on fluoroscopy contrast examination, which is a spiral appearance of the bowel. Another imaging technique, such as ultrasound and computed tomography, show a whirlpool sign, which is used to denote twisting of the bowel on itself. A LAD surgical procedure is done to treat midgut volvulus, which entails dividing the tissue that creates an attachment between the cecum and the abdominal wall called Ladd's bands, widening the mesentery of the small intestines, removal of the appendix and proper placing of the colon and cecum. Patients with sigmoidal volvulus often have abdominal bloating, constipation, and nausea that may or may not be accompanied by vomiting. Sigmoidal volvulus is considered to be associated with neurological pathologies such as multiple sclerosis and Parkinson's disease. The causes of sigmoidal volvulus include the South American Chaga disease, laxative use, and diets rich in fiber. A whirlpool sign is also seen in sigmoidal volvulus on imaging. In addition, a coffee bean sign may be seen on the abdominal X-ray that will look like an inner tube that is bent. In most of the cases, the insertion of a rectal tube is found to be successful in treating sigmoidal volvulus. Cecal volvuli are predominantly associated with 2 predisposing factors: lack of thorough peritoneal fixation and fulcrums such as abdominal masses or adhesions. Patients with cecal volvuli tend to have distended abdomens in addition to colicky, abdominal pain, and vomiting. Nearly half of the patients with cecal volvuli tend to have a cecum that is abnormally rotated in an axial plane, while the remainder have a cecum that inverts in addition to twisting. Treating cecal volvuli may involve laparotomy, hemicolectomy, or cecostomy.
You hear an interview with a midwife called Susan Porter, who's talking about when to cut the umbilical cord. You now have 90 seconds to read the questions. Today we're talking with midwife Susan Porter about a rather controversial topic. Susan, why is the question of when to cut the umbilical cord of a newborn still so significant? And can you give us a brief history of the subject?
Well, you're right in that this question has always been a remarkably controversial topic, and some new research carried out over 8 maternity units across the UK indicates there's good reason for never having let it go, as the evidence now seems to suggest that delaying clamping and cutting the cord after birth could improve survival, specifically in babies that are born prematurely. It all started in the 1960s. Shockingly, before that time, women were still regularly having massive bleeding at the time of childbirth and were dying, which then prompted the testing of a new drug, an injection that clamped the womb down within seconds. It was the magic bullet they've been looking for, because it appeared to be very effective at preventing postpartum hemorrhaging. But of course, there were concerns about that, too.
Can you tell us more about that?
One of the worries was that it worked so well that it would squeeze extra blood into the baby, effectively filling the baby with blood. So they very quickly developed the practice of clamping the umbilical cord only moments after delivery. Obviously, clamping is inevitably necessary, but thinking has changed so much now that it's a little strange to think that even in the 1980s, the only reason for not clamping within a 10-second time frame was if you dropped the clamp and had to go and get another one. In other words, it was immediate.
And what happens if we don't clamp a baby's cord?
Well, the circulation between the placenta and the baby will continue for a period, and recent research has shown that it probably continues for longer than we'd previously thought. So if you keep the baby at more or less the same level as the mother, and just don't touch the cord, that flow will continue. That's how the baby breathes before it's born, so you need a bit of a transition for the baby to start breathing through its own lungs, particularly if the baby's had a vaginal birth, as it's been squeezed in all sorts of ways. And maybe just leaving the baby alone for a few minutes allows it to stabilize its own heart system and also establish its own respiration. It sounds very unscientific, but it's a system that's been designed to work that way, and it's us interfering early that was changing that system.
What's the standard waiting time before clamping these days?
People typically use either 30 or 60 seconds, which is still fairly quick. I find it amazing that in the age of potentially sending a person to Mars, the best time to clamp still eludes us. In one unit I know of, for preterm babies, they absolutely delay. Healthcare professionals to this day still argue about it. The problem is that there have been dozens of previous trials, and they were very poorly executed. The trials all showed it was better to wait, but scientifically nobody really believed the results. They simply didn't trust them. The UK trials seem to have demonstrated very clearly that for preterm babies at least, waiting is optimal. The unit I just mentioned now waits 2 minutes.
And what's your take on the benefits?
If it reduces the chance of a preterm baby dying, that's the best possible outcome. I think parents understand the logic. I doubt a parent would say they don't want it. They'd say, yes, I can see the benefits of trying this. and especially if it's explained to them that the potential harms of letting the baby go cold are far outweighed by the increased chance of survival. An interesting offshoot of this is the positive change for the mother, as it reduces what was once the norm of mothers having their babies transferred away from them, where the first thing they see is a photograph.
Based on what you see, how likely is it that extended times will become universal?
In babies that are born early, all the organs are still immature, and that means both its heart and the blood vessels in the brain are not fully developed yet. So one of the big problems is hemorrhagic stroke. Also, they're not ready to start breathing on their own, so just by leaving the cord alone, there is better oxygenated blood in the placenta than there is in the baby. The cord gives them access to this. It's essentially a backup to allow more time for the baby to establish its own respiration. This really can't be denied or disputed any longer. I mean, what are the drawbacks? I think change will be gradual across the board, and in years to come, we'll look back on these days and ask ourselves what took us so long.